All right. So let's start. So I'm Ben Williams, Program Officer from the Helmsley Charitable Trust. So on behalf of Helmsley and the Scientific Organizing Committee of this meeting, welcome. It's really good to be here. This has been something that we've been wanting to do for a while. It's something that we think is really important. This field of restoring alpha cell function and glucagon secretion in diabetes we think is ripe for scientific discovery, but more importantly, there's a huge potential to translate things that are going to help people with type 1 and type 2 diabetes. So thank you very much for coming. I want to kick off the meeting by welcoming Al Powers from Vanderbilt, who's going to continue the introduction and keep us on our way. So thank you.
Thanks very much, Ben, and I want to congratulate you and especially Kanchi for organizing this meeting. I think you've brought an interesting group of people together, so I think that's going to be very fruitful in terms of having discussions across disciplines in that. So congratulations and welcome. Okay, so I'm just going to give opening comments, very little data, but hopefully to set the stage and to set the context for today. So I don't really have any disclosures about anything, except that I have been fortunate to be supported by the Helmsley Charitable Trust. They've done a great job at supporting so many new initiatives like this. And so today, here's what I'd like to just do in my next 8 to 10 minutes. Today's focus of the meeting is really on islet biology, and that the organizers who've done a great job of putting the program together have asked us to focus, and we're really not going to focus on insulin delivery or new insulins or beta cell replacement. But I think we're going to highlight how incomplete understanding of hypoglycemia and how it's prevented normally and how the physiologic defense systems become defective in diabetes. You're going to hear several sessions this morning that are going to address that. And then what we really want, the organizers want to do is promote discussion across the spectrum of investigation. There are people here who are ion channel people here, there are people who are clinical trial people, there are people who are clinical physiologists. So really we want to break down those barriers and talk across talks and disciplines. So hopefully that will happen. And I really want to provoke us to think about translation in the fullest sense of the word. Often we say translation, and translation to one person means something different to something else. And so I'm going to show you sort of one way that we might think about that. And while I'm going to point out some challenges, I think there are lots of opportunities and in a very exciting area. So, here's the problem that we have. So these are data from the DCCT. These were published many years ago. On this graph shows the chance of developing retinopathy. On this graph shows the risk of hypoglycemia. So as one lowers the A1C, reduces the risk of complications, there comes the problem with hypoglycemia. So these are the two dilemmas that we have to face, is how do we improve glycemic control here without this baggage here. Now, when we look at diabetes, we know that it is not a monolithic disease. Everyone on this slide has diabetes, but we know that they have different forms of diabetes, even though we don't talk about it. We know that there is heterogeneity, great heterogeneity in type 2 diabetes. We know now that type 1 diabetes also has heterogeneity. And then the duration and the age of that also impacts that. So I would argue that there's great heterogeneity in diabetes, and what we don't know is how much heterogeneity there is in hypoglycemia. I think one might predict that hypoglycemia is not monolithic, that there's not just one form or one mechanism of hypoglycemia, and that there is likely considerable heterogeneity among individuals in how they either develop hypoglycemia or they respond to that. So, these are all the organs that regulate our blood glucose. And so we know a lot about the ones that make the glucose go up. So, we have GWAS studies in type 1 and type 2 that point to lots of genes that increase the risk of those. In my reading of the literature, there's very little about the genetics of what might, genetic loci might alter the response to hypoglycemia, whether one develops hypoglycemia, whether something like this. So Steve Rich and I last night were talking about this in dinner, and it's likely that the loci, if they're likely loci that are here, we don't know what they are, but they're likely to be different than the ones that are for the risk of the disease. This slide is one by the pioneer in this field, Phil Cryer, who passed away this last year. Lots of arrows, lots of things that are regulated. So I show this just to say the complexity of the system that we have to try to maintain our blood glucose. And so we're going to focus today on this glucagon response here. But also important is the response by epinephrine. Mike Rickles will talk about that a little bit today. But as we think about hypoglycemia, our focus today is on that part, but there are lots of other parts of that influence the glucose and the individual's response to the low blood glucose. So if one looks at the CGM profiles, I just want to point out a couple of things about this. So here are some patterns as you go along the time of the day here, with the target range as shown here in green. One thing I would point out is that things move, but they move over a period of minutes to hours, not over seconds, right? So as we think about interventions, we want to change the trajectory of these curves. We don't have to raise it acutely unless the glucose is quite low. But one sees these patterns that happens. So, and if you look on individual scales down here, so say here's on Tuesday, this person became hypoglycemic and then they rebounded too much. So as we think about the ways that we want to prevent hypoglycemia, we want to prevent this, but we don't want it to lead to this afterwards. So there are 3 levels of hypoglycemia that have been determined, less than 70, but over 54, level 2, and then any level where one's not able to take care of themselves. And so sometimes called severe and moderate, but these are the ones that we really are focused on. And the assumption is that if you prevent these, you will ultimately prevent those. Now there's a lot of data about, now we have CGMs and what's going on. So I'm going to show you 2 studies that were just published in the last few months. This is from the HypoResolve study. And so they looked at they reported the relationship between sensor-detected hypoglycemia and patient-reported hypoglycemia, because those are not the same thing, even though we often think about them being the same thing. And so these are mostly insulin-treated type 1, but there were some insulin-treated type 2. And one can see that when you look at sensor-detected hypoglycemia less than 70, here shown here, symptomatic hypoglycemia here, there is overlap, but there are a lot of people who had sensor-detected hypoglycemia, and there were people who had symptomatic, they thought, hypoglycemia in there. So it shows you that the symptoms are really important, but can't tell you everything. And then the other study I wanted to point out was one by Jeremy Pettis, where they looked at severe hypoglycemia and impaired awareness. And they, you thought that, okay, now we have CGM, this is no longer a problem. Well, it turns out it's still a major problem. They reported, and these are the type 1 exchange, 50% of them didn't have their A1C, 20% had a severe hypoglycemic episode, 12% had 2 of those, and approximately 1/3 of the people had impaired awareness of hypoglycemia. So in this day, with all of our sensors, bells, and whistles, it's still a major problem. I just want to add a little bit of complexity to you as I finish this out. This looks at, this is Richard Oram, looking at the risk of type 1 diabetes, and maybe 1/3 of the people who develop it over the age of 30. And so one question I would pose to you is there heterogeneity here? So is hypoglycemia in this 8-year-old and in this 65-year-old the same? Are interventions similar in those 2 age groups? As we know that many, many people live now with type 1 diabetes for 20, 30, 40 years. How does their hypoglycemia compare to those with relatively recent onset? Another thing to think about is we know that the pancreas is changing in individuals as they have longer duration type 1 diabetes. For example, this is the size of the pancreas is getting smaller the longer they have that. And here's a pancreatic islet from someone who had type 1 diabetes for 20 years. So if one thinks about drugs or agents that target islets, the islets of longstanding type 1 diabetes does not look like the islets of autoantibody or relatively recent onset. So I'll just finish by saying, look, there was a movie by Bill Murray, like Lost in Translation. I sometimes think we get a little bit lost in translation. So I'm going to just talk about translation. We think about, this seems pretty obvious there. We have model systems. But I think we need to enlarge our thinking about that so that we involves not just clinical research, moving it here to here, but also how do we devolve it into clinical trials? And in these clinical trials, we have to think about our patient populations may be heterogeneous. So how do we decide and choose people, young, old, duration of diabetes? And because ultimately what we want to do is have impact on people who have type 1 diabetes. So thanks, Ben, for letting me make some opening comments. And we're going to have the sessions that we have today. We've got moderators for each of those. And each of those sessions, I've put things like, why are alpha cells dysfunction? What's the changes in gene expression? Primary, secondary, what's the relationship to loss of beta cells? How do we understand and restore? We're going to hear from people about clinical models, hypoglycemia, heterogeneity, and then clinical progress and regulatory perspectives regarding strategies later in the afternoon. And how do you test those strategies? And I think as in all of this, we have to think about how we need the input and the involvement of individuals who have type 1 diabetes in designing the trials and developing therapies that ultimately will help them and ones that they'll choose. So thanks, and I'll end there, and I guess I'll introduce Gina, you're the first moderator. Please, Gina.